So we know it's a major global health problem and is the most common medical conditions women. ये इतना disturb से यहाँ अच्छी यहाँ आ रहा है. Okay, it's a most common medical condition which women encounter during pregnancy. 1 in 6 live births occur to women with some form of hyperglycemia, 84% of which are due to GDM only. So that means 16% are due to overt diabetes. Hyperglycemia or GDM is associated with our leading cause of maternal mortality, morbidity, and higher incidence of perinatal and neonatal morbidity, later long-term consequences for mother and baby. And GDM is defined as impaired glucose tolerance of variable severity with onset seen during first time during pregnancy. Ideally after 20 weeks, and if it is diagnosed before 20 weeks, it will be diagnosed, usually said as overt diabetes. So it's a major global health problem, and the WHO Director General in 2011 said we are facing a slow motion disaster at a UN meeting on non-communicable diseases. So diagnosis and management may help turn the tide of diabetes and non-communicable diseases pandemic. So the challenge is nearly 127 million live births. They occur across different countries. 21 million are complicated by hyperglycemia. 3 to 4 million are detected and treated, and rest are not treated. And very few receive. So these are the circles which are indicating very few percentage they receive postpartum care and lifestyle advice. So some facts are gestational diabetes is diagnosed during pregnancy, prevalence being 17.8 in urban and 13.8 in semi-urban. But it is expected to reach 20% in near future. 90% cases GDM disappear after delivery, but 50% of women may develop diabetes in 5 to 10 years. 70% patients don't need medicine, and diet therapy alone can check. Screening during pregnancy can save mother and child. And India glucose challenge test is simple. Form is screening. Due to their lifestyle, Indian women are at 11-fold times increased risk of developing GDM. So we need for early detection. Why? Because we are trying to detect a future potential and trying to see that the baby is not programmed. Because the fetal pancreas, they develop at 10 to 13 weeks of gestation. So this is a new guideline which is coming, that it says that if you screen for diabetes, for impaired glucose at 8 weeks of pregnancy, and if she turns out to be, just do a postprandial 2 hours, and if it is greater than 110, simple postprandial, no glucose overload. If it is more than 110, you start giving metformin, 250 milligrams to that patient, so that you do not let the baby's pancreas get programmed to hyperglycemia and produce more insulin. So this is maternal hyperglycemia leads to beta cell hyperplasia, hyperinsulinemia, and macrosomia, and childhood obesity. These are some different consequences, but here we are trying to program the baby not to be diabetic in the next generation. So early maternal metabolic imprinting may affect offspring's growth, therefore early diagnosis is recommended. So this was 2 hour postprandial as blood glucose level greater than 110. So the maternal morbidity associated with GDM could be in early pregnancy resulting in spontaneous abortion. In pregnancy, preeclampsia, polyhydramnios, excessive fetal growth. And GDM doubles the risk for gestational age baby, gestational hypertension or UTIs. In delivery, there could be preterm labor, instrumental delivery, traumatic labor, and post-operative and postpartum infection and hemorrhage. Increased risk for cesarean section, thromboembolism, and maternal morbidity and mortality. In puerperium, there will be failure to initiate or maintain lactation, and risk for infection is increased. Long-term postpartum would be weight retention, GDM in subsequent pregnancies, future overt diabetes, and future cardiovascular diseases. So we have to be on the lookout for NCDs basically. In neonates, stillbirth is 1.5 times more. The neonatal death could also occur. Non-chromosomal congenital anomalies can be seen. Respiratory distress syndrome, neonatal hypoglycemia, neonatal hyperbilirubinemia, Erb's palsy, shoulder dystocia, cardiomyopathy, neonatal polycythemia, hypocalcemia, and programming and imprinting of the fetus for obesity, diabetes mellitus, hypertension, and metabolic syndrome. So high risk factors predisposing a woman for GDM would be history of GDM, age above 25 years, first degree relatives with diabetes, pre-pregnancy obesity greater than, BMI greater than 25, bad obstetric history, that stillbirth, congenital anomalies, RPL, eclampsia, polyhydramnios, large for gestational age babies born in the previous pregnancies greater than 3.5, repeated or persistent UTI, and glycosuria during pregnancy. The screening is universal and it has been suggested by IADP-SG, ADA, WHO, and DIPSI, and we are following that. So the recommendation, DIPSI recommendation is a single step, simple. The lady comes to you, irrespective of the meal she has taken, give 75 grams of glucose dissolved in 300 ml of water, and she should finish that in 5 to 10 minutes. She has not to exercise. She does not have to roam around. She keeps on sitting idle, and after 2 hours, and if you do a blood sugars, so cutoff is 140. If greater than 140, she is labeled as GDM. Less than 140, we go to subsequent screenings. And if vomiting occurs within half an hour, you have to repeat the test next day. And if it occurs later than 30 minutes, you continue the test. So screening recommended twice in ANC. First testing at first antenatal contact, you were asking. And second is at 24 to 28 weeks of pregnancy. If first is negative, 4 weeks of gap between the two should always be there. Right? So first contact, suppose the patient comes at 26 weeks of pregnancy. So you're not repeating at 28 weeks again. So there should always be a 4 weeks gap between the two. And if pregnant woman comes beyond 28 weeks, then test is done only once. So universal testing, this is a pregnant woman comes and you give this DIPSI testing, and positive, negative we have already done. On self-monitoring, there are many patients who are not ready to take glucose, right? So on self-monitoring also the option is there. Then the levels, postprandial levels are 120. Okay, less than 120, she is non-diabetic, and greater than 120, she is labeled as GDM. So this is a difference between impaired glucose tolerance in pregnancy, outside pregnancy, but it is very clear. This confuses, even I've taken the chart, but still confuses. Only 140 is the cutoff. Above 140, it is GDM, and above 200, agar even in third trimester or second trimester it comes like that, then you can take it as an overt diabetes. The patient was undiagnosed, somehow she's come late to you, and if it diagnose it before 20 weeks, then obviously it is overt diabetes. So treatment is 70% control on MNT, 25 needs pharmacotherapy, and only 5% needs insulin therapy. Management is very simple. You start with the lifestyle modification of diet and exercise. You start with medical nutrition therapy, calorie modification according to energy requirement. If not controlled, then you go to pharmacotherapy, and we try this for 15 days, and then we go to pharmacotherapy. Oral hypoglycemics, metformin to be started ideally greater than 20 weeks. Glyburide can also be considered. And if not controlled, go to insulin, and high doses insulin required. We can add metformin again to balance the dose of insulin. So this is a management which the government guidelines. So this is the desirable weight we have calculated from the ideal weight and height chart. What should be the total weight gain? If the patient has a BMI of 18.5 to 24.9, 11.5 to 16 kgs, less than 18.5, 12.5 to 18 kgs, and if she is overweight, only 7 to 11.5, and greater than 30 BMI, only 5 to 9 kgs. So insulin therapy, first line test is considered when the diagnosis of hyperglycemia in pregnancy is less than 20 weeks, or we are starting treatment beyond 30 weeks, or the fasting plasma glucose comes greater than 110, 1 hour plasma glucose comes at greater than 140, or the pregnancy weight gain has been more than 12 kgs. But ideally, insulin is the gold standard. If the patient is really very fussy, then only you can try, because over here, you just have to make the patient understand that they always ask, we give them a drug, they ask, ये मेरे बेबी को नुकसान तो नहीं करेगा. There your natural glucose is acting as a teratogenic agent. So you have to be very particular and treat it. So glycemic targets, fasting plasma less than 90, 1 hour less than 140, and 2 hours less than 120. So what is the obstetric care? There's a gynecologist should be the healthcare provider. ANC has to be if the patient is controlled, then monthly, uncontrolled bi-weekly till 28 weeks, and weekly thereafter. Even if controlled, I think this should be done, right? Bi-weekly till 28 weeks and weekly after. And monitor abnormal fetal growth, macrosomia, growth restriction, polyhydramnios, hypertension in pregnancy, and other complications. Counsel for differential fetal movement count. Contact healthcare provider if the fetus does not keep for 10 times within 2 hours. And ultrasound anomaly scan at 18 to 20 weeks. Growth scans 28 to 30 and 34 to 36 weeks. Keep a gap of minimum 3 weeks between the two ultrasounds. And what we are looking on ultrasound growth and all we are looking for fetal biometry and amniotic fluid estimation. So fetal surveillance, particularly auscultation of fetal heart, close watch as the risk of IUFT is higher. Risk for more when there is medical requirement of medical management. Daily fetal movement count if fetus does not give for 10 times within 2 hours, report to the clinic. Fetal growth scan, fetal biometry and AFI estimation at 28 to 30 weeks and repeat after 4 weeks. So if GDM between 24 to 30 weeks requiring delivery, then give antenatal steroids, dexamethasone 6 milligrams IM 12 hourly, total 4 doses. More vigilant monitoring of blood glucose level for the next 72 hours. In case of raised blood glucose levels, raised dose adjustment of insulin is done accordingly. So where should the patient deliver? No home delivery should be the dictum. Deliver at respective health facility only if there is a good control of blood sugar, but deliver at a higher center if the blood sugars are not controlled or the patient is on high dose of insulin therapy. So timing of delivery, ideally it has to be individualized, but per se we do not say induce delivery below 39 weeks. Delivery less than 39 weeks not recommended as respiratory maturity is delayed. Deliver early with poor glycemic control or hypertensive. There is another complication. Hypertensive disorders of previous stillbirths. Vaginal delivery is preferred. Cesarean only for obstetric indications. Consider primary cesarean at 39 weeks to avoid shoulder dystocia if fetal macrosomia greater than 3.5 kgs according to Government of India guidelines. Western say 4 kgs. So postpartum care, immediate postpartum care of GDM women is same as non-GDM, but maternal glucose monitoring has to be done. Maternal glucose usually returns to normal after delivery. Evaluation of glycemic status done after 6 weeks by 75 grams OGTT, fasting and 2-hour PP. Test normal, counsel about lifestyle modifications, weight monitoring, exercise and annual screening for NCD. So GDM and contraceptive advice, risk of unplanned pregnancy outweighs the risk of any contraception given contraception. So any contraceptive method is safe for a woman with GDM and even with diabetes mellitus provided they are controlled. That has to be the bottom line. Copper IUD and barrier are category 1, rest all are category 2, except for combined hormonal contraceptives and injectable progestin only contraceptives, which are category 4 or 3 for women with complicated diabetes or diabetes greater than 20 years of duration. So nothing is more expensive than a missed opportunity. This is an opportunity when a woman is coming to you, and ANC, education and counseling about potential long-term risks to the mother and newborn and preventive strategies for diabetes in postpartum and interconceptional period. So if the lady is coming to you in the next, she comes to you in pre-conceptional time, she wants to conceive again. So what are the risks? There is a relative risk of developing type 2 diabetes, which is 4.69 times in the first 5 years and 9.34 times at 5 years after delivery. Education for risk, diet, exercise, hypoglycemia and self-monitoring of plasma glucose. Folic acid supplementation 4 mg per day. Treat hypertension before pregnancy. Optimal BP control should be less than 130 by 80. Discontinue use of hypoglycemics, ACE inhibitors, ARBs, statins and fibrates. Because we said at oral hypoglycemics, less than 20 weeks, insulin should be ideal case, right? So retinal assessment by fundoscopy, renal assessment including microalbuminuria, thyroid function 5 to 10% incidence with diabetes, and evaluate for neuropathy. Thank you.